Good afternoon, everyone, and welcome to UCSF Family and Community Medicine Grand Rounds. Our speaker today is Dr. Katherine Mathews, who I'm very excited to hear from today. She'll be talking about preparing our students to be leaders and change agents. But before we get started, just a few housekeeping announcements. The first one is what you probably already know, which is that this session is recorded. We are excited to have a really engaging discussion today, so I'm hoping everyone will go ahead and use the Q&A to submit your questions or comments for Dr. Mathews, and we will have a discussion about them at the end of the towards the end of the session. There will be lots of time for interaction. I want to thank our fabulous tech team today, Roy Johnston, Benjamin Wallen. Very happy to have your help as always. If you are interested in reviewing today's session, or you missed previous grand rounds, or you just want to watch them all over again, you can find all of this on our Family and Community Medicine, UCSF Family and Community Medicine Grand Rounds website. All sessions are recorded and available to watch within about 3 days after they happen. So there's some great sessions there. And last but not least, a shameless commercial, which is, if you like grand rounds, if you think this is exciting and you'd love to have a whole day of engaging with educators and thought leaders and sharing your ideas and being part of the dialogue, please join us for the UCSF Family Medicine Rodnick Colloquium on May 16th at Mission Bay. If you check out our website on the FCM website, you can sign up for it in advance. And we're hoping that we will have, we know that we will have folks from all of the UCSF Family Medicine Educational Alliance sites, and hopefully broad participation from the community. So regardless of whether you're a student, resident, staff person, or faculty member, we'd love to have you join us. Please sign up. And I would love to introduce Dr. Mathews, but I think my screen is not, hang on, there we go, got it. There we go. Okay, now I can actually read her a little bit about her bio to you today, which is an impressive one. Dr. Mathews is an OBGYN with a background in international work, healthcare administration, and public health. She's lived and worked in St. Louis, Missouri for over 25 years and has been engaged in many regional initiatives to improve access to quality care for low-income communities. Dr. Mathews currently serves as the Associate Dean of Health System Science at St. Louis University School of Medicine, where she teaches leadership and oversees many community-focused initiatives. Today, in this Grand Rounds presentation, what Dr. Mathews will be discussing with us is strategies for training medical students to be leaders and change agents in medicine and in society at large. Many medical students bring passion to our profession and are often distressed to learn about the entrenched structural inequities within the U.S. healthcare system. This combination of passion and distress can lead students to jump to solutions that have the potential to do more harm than good. By focusing on self-awareness, moral humility, perspective-taking, teamwork, and cultivating a lifelong learner mindset, Dr. Mathews prepares students for leadership as a long-term endeavor that is best done in partnership with others. She will review the opportunities and challenges to this approach. And to say, when we were talking before this session, Dr. Mathews said, well, really, I have more questions than answers. And I would echo her sentiments there. So I'm hoping that you will share your questions and thoughts in the Q&A. And with no further ado, I will welcome Dr. Mathews. Thank you for joining us.
Thank you so much. It's really my pleasure to be here. So I have no disclosures. And as you just heard, when I originally thought of this presentation, it was in this space of how we best prepare our students. And this issue of jumping to more harm than good, or creating solutions that have cause more harm than good, is not just theoretical for us in St. Louis. So both here at St. Louis University and our sibling med school in town, Washington University School of Medicine, both have had student-run free clinics. And in recent years, both institutions have shuttered those free clinics. And beyond that, we have a number of student interest groups in the community. And again, both institutions, I'm not really speaking for WashU, but I did recently speak about this with their leadership. We're both really thinking about ways to make sure when students are engaged with work in the community, that it's truly to benefit the community. And the fundamental issue being, students, we can have great intentions, but that doesn't always lead to great programming. And so on our end here at SLU, we've been working at a new system to ensure that there's always proper training for students. There's faculty ownership of community-facing work, which is difficult when faculty are under a lot of clinical pressure to generate revenue. That patients understand that we are working with learners just as they would understand when they come for care in our medical systems, our hospitals. And particularly for us, we want to make sure that any work we do is integrated into our broader systems of care. And so the photo I'm showing here is of our former student-run free clinic called the HRC. And for a variety of reasons, partly we had to move out of the building, we closed that clinic a little over a year ago. What happened? The truth was that it was actually students who brought these issues to my attention. I wasn't involved with the HRC at all. And in fact, this was prior to me having a dean role for health system science. And there were two quotes in particular that really struck me from our students. One was one of the students who had been a lead for the clinic, who came to me one day in distress and said, "Dr. Mathews, we're practicing on poor people." And the other quote that came to me was that this student-run free clinic was providing substandard care to people who needed the best care possible. Although this clinic that was founded in the 1990s was originally set up to address unmet need, and at that point we did not have as robust and well-coordinated a safety net system, the clinic over time had drifted, and especially during COVID, it became a place where our first and second year medical students were practicing clinical skills without always having sufficient oversight and without being linked into a broader system of care. So instead of having this foundational ethical approach, which always puts patients and the community at the center, it had become an environment where students were at the center, and it was about meeting student needs. The other thing to mention, which I've alluded to, is over the past 20 years, the organizations in town here that provide care to underserved populations, our academic medical centers, our federally qualified community health centers, and our county Department of Health clinics, have done a much better job of coordinating. And so we're right on the Mississippi River. It's the boundary between our state and Illinois. So on the Missouri side, that system in the St. Louis region covers 100,000 lives. And then on the Illinois side, they have a similar system. So I had said, and I wanted to talk about some of the teaching I'm doing with my own coursework that really helps to bring students into a space where they don't just jump quickly to a solution, assume that there's an easy answer for complex problems. And I will talk about how I do that in some of my coursework and how I even became a course director and some of the background to that story. But the more I thought about doing this presentation, the more I realized that this isn't just a student issue. And what I've wanted to be really thoughtful about is that for our students, as they are looking ahead to residency applications at a time when step one has gone pass fail, that they experience this tremendous pressure around distinguishing themselves. And this, I think, is part of where that desire to run their own clinics, do fantastic things in the community, solve gigantic problems within a year's worth of time, some of that pressure becomes more real for students because of the uncertainty about matching for residencies. And so my question to us today, and for us to think about going forward, as a community of educators, what can we do to address these tensions? And here's my image for this jumping to solutions, which I had named when I began to think about the presentation, can in part be arising from a sense of pressure about needing to do great things. So what I want to do is start with a little bit more of an introduction about our med school, the region, myself. I then want to talk about the course I've had the privilege to develop over the past few years and come back then to this notion of student pressure and open it up for your questions and input. So I'm at St. Louis University, which we call SLU. We're one of just a few Jesuit medical schools in the country. And I know in San Francisco, you have University of San Francisco, which is a Jesuit institution. And so some of you may be familiar with some of the core values for Jesuit academic institutions. I think in the olden days, I would hear men born with others or men and women born with others. I like now to say people with and for others. And I like to put the with for first, because to be for someone, I need to be with them first to know them and to know the life that they are leading. We have the concept of cura personalis, so a focus on the whole person. Jesuit institutions often think about the greater purpose of the work that they're doing, and often within Jesuit pedagogy, there are intentional cycles of action and reflection. Within our medical school, we have 180 students per year. We have a handful of joint degree students. And in recent years, we have new leadership at the top of the medical school, Dean Chris Jacobs. We've really intentionally said that we're going to play more of a role of training physicians for our region. Although I think like many Midwestern schools, we do have a lot of students from California, but we are very proud of the fact that in our M1 class, over 100 of the students are from Missouri and Illinois. When we think about characteristics of our students, and I was talking before the presentation, I'm really very clunky with poll everywhere, and this is a completely non-scientific study with categories that I made up, but it's something that I shared with our first year students this fall. And I gave them this list of reasons for wanting to become a physician. And I said, please check all that apply. And then they couldn't see what other students were responding. I was trying to avoid having people just kind of go, okay, what's the trendy answer? And to really discern what it was that made them feel this call to be a physician, to be in the healthcare profession. So not surprisingly, the number one answer was to help people who are sick and suffering. And then there were two follow-up categories: use my gifts and talents to their fullest extent. And the one I was looking for was this desire to make the world a better place, because it's my sense that many of our students come to med school with these broader agendas about positive social change. And so I wanted to bring that out in my discussion with our new first years. In terms of the history of St. Louis University, I thought I would tell a bit of a story here. I love to do narrative presentations. So SLU claims to be the first medical school west of the Mississippi, and I'll tell you why that's sometimes debated. The school was founded in 1836, but had a bumpy start. The university and the medical school parted ways early on, and then there was an independent St. Louis College of Medicine that then became Washington University. And somehow we don't really tell that story, but it is available online on our history page. What's interesting to me as an OBGYN doctor, where we've dealt with legacies of racism within our profession, is that Marion Sims, who was frequently called the father of gynecology when I was going through training, Marion Sims, who's known to have developed a lot of surgical techniques by experimenting on Black women and not using anesthesia. When SLU restarted as a medical school in the 20th century, they acquired what was called the Marion Sims Beaumont College of Medicine. And that's a piece of our history that some people are aware of, but I don't know that we've really fully processed. I don't think Marion Sims really had much to do with St. Louis, Missouri at all. And I think the name was chosen just the way that Washington University chose to name themselves after the first president of the country. In terms of schools that also claim to be west of the Mississippi is Tulane, so I don't want to ignore that claim, but you will see here that when you get down into Louisiana, the Mississippi kind of curves around. And so if you were to straighten out the Mississippi, we in St. Louis and at SLU would say we were still the first school west of the Mississippi. Here's our state. I indicated that we're right on the border with Illinois, and it's the Mississippi River that's creating the boundary here. And you will see that that little fingernail of dark blue is St. Louis City. The city is its own county. It's separate from the broader county. And you can see that we are a blue city in a red state. This connects very much to the history of our region, where St. Louis was a Union city and a slave state. For those of you who are history buffs, Missouri came into the Union as a slave state through what was called the Missouri Compromise, and that's when Maine was added on as a state. We are the location where the Dred Scott decision, Supreme Court decision, was made that basically said that even if a slave had been freed, that basically they had no rights as a citizen within the US. And so Dred Scott, a freed person, was deemed not to have rights of freedom in this country. The city I showed you being separate from the county, that's called the Great Divorce, and that happened also in the 19th century. And at that time, all the wealth was concentrated in the city, and we now have the flip. All the poverty is concentrated in the city. We had a nationally renowned medical school residency training program, actually a hospital here called Homer G. Phillips Hospital, that trained a number of Black physicians and nurses and allied health professionals. People came from around the country to go to Homer G. That was closed in the late 1970s to great public uproar. We're the location where Michael Brown was killed in 2014. We had the Ferguson uprisings. And then the reason I've kept this photo up of SLU through much of this part is there was another young Black man killed near our campus shortly after Michael Brown's death. There was a sit-in protest at the university called Occupy SLU. And what resulted out of that protest was something called the Clock Tower Accords. And although SLU has always been community focused, in 2014, in the fall, there was a whole new set of commitments that we wanted to make to our community. And then just to keep in mind, and one reason I go into the history is that we are a part of the country with embedded segregation. There's been attention to segregation in the city of St. Louis with a piece called the Del Mar Divide, which was actually featured by the BBC. So this line where we see extreme differences in wealth and education level, just kind of one side of the street versus another. And then we have poor health outcomes in our urban areas, but also in many of those rural areas, those red parts of the state also experience a lot of poverty. We have a really diverse city population. We have immigrants and refugee populations here, so a number of languages other than English are spoken. And then interestingly enough, I've referred to WashU. I used to work there. We are now one of 3 med schools in the city of St. Louis. The third med school is Ponce, which is based, its main campus is in Puerto Rico. Our city it's just under 300,000 people. The MSA has close to 3 million people. And what's interesting, again, if we think of these issues of structural inequities and haves and have-nots, there's a lot of healthcare industry based in St. Louis. And so according to the regional kind of bio startup organization, BioSTL, we have 10% of all US healthcare spending is based out of companies that are based in St. Louis. So it's a sobering disconnect when we think about the degree of poor outcomes we have, and especially in my work, especially around infant and maternal health. So my own background, and this is all leading up to where I come to our work with our students. My pronouns are she, her, hers. I am someone who, like the students we have now, often faced uncertainty in my past. And when I felt uncertain, my approach was just to go to another school. And so I had intended to be a physician for a long time, but over the time, I've also studied theology, public health, and business administration. I have a 19-year-old who lives in New York City. And as you heard, I'm in OBGYN. I'm our inaugural Associate Dean of Health System Science, and I oversee some of our community-facing work. As a young person, I really did have that similar intention of wanting to make the world a better place. And before I went to med school, I spent a couple years in East Africa working with the church in the Anglican Diocese of Kilimanjaro. And it was here where I was fortunate to learn the very hard lesson that coming in with this need to achieve things, this need to do something significant, often could cause harm. So not only did I have my own impulses checked, I also saw how when other people came into East Africa from outside and imposed their good ideas, that it often really blew up. And I was also fortunate to be counseled by 2 physicians who ironically had trained at Hopkins and had MPHs and lived in Tanzania. And they chastised me that if I really cared about making change in community, I needed at least a year to begin building relationships. So years later, when I moved to St. Louis in 1998 and intentionally chose to work north of Del Mar in the Black part of St. Louis City at one of our FQHCs, I brought that lesson from Tanzania with me and really sought out to build relationships and then to see where I personally could be of service. And so I have worked when I was at WashU, it was with the Siteman Cancer Center, worked on a lot of public health programs. I've worked on other initiatives in the region to improve access to care, worked at Medicaid policy at the state level. And I have had some kind of connection to SLU, first with the School of Public Health, but for over 20 years. With all this work, I've then learned, and I have the benefit now of being able to look back and go, wow, that took me a long time. That change, and especially change to make the world a better place, is a long game. And I also learned that even though I have only worked for nonprofit organizations, that much of what drives organizational decision making or individual behaviors is how the money flows and what incentives are in place. I was saying to Margot before the talk that one reason I moved into education was about 15 years ago. I thought, if I care so much about public health and I'm just one person, another way to really be making progress around public health, our systems of care, was here in St. Louis to be working with the next generation of leaders and change agents. And so that's been an intentional focus for me for some time. So I'm going to change gears a little bit now and talk about how I came into teaching and the actual course that I'm teaching, which gets to some of these key concepts I want to talk about in terms of helping prepare students in a different way from the prep for step 1 and step 2. At St. Louis University, we have something called the Bander Center for Medical Business Ethics. And this center was put in place some time ago, but in 2019, the opportunity came up to create a new required curriculum in our pre-clerkship, which for us is now a year and a half. So before students enter the wards and clinic and hospital spaces, to create a curriculum that was focused on the values of the Bander Center. And what are those? The Bander Center was founded by Dr. Steve Bander, who's still here in town, who was a nephrologist and had been working in the dialysis sector. And he had worked for companies that got acquired by larger and larger companies and found over time that decision-making within those companies had veered drastically away from evidence-based care, what was right for the patients, and was really being driven by what generated more margin or profit. And so he tried to change this from the inside and got fired. And so he did a massive Medicare whistleblow in 2001. The company at the time was called Gambro, and they since have been absorbed up into what is now DaVita. At the time, this was the largest fraud case in Missouri and the 6th largest ever in the US. Steve is the gentleman with the dark hair. Steve received an award from Robert Mueller when he was director of the FBI, his Community Leadership Award. You may remember Mueller from the Mueller report, but that's a different story. And with that Medicare whistleblow payout, Steve endowed the Bander Center for Medical Business Ethics at SLU, also donated money to WashU, and really wanted us to figure out ways to teach students, residents, and physicians that knowing the right thing does not always mean doing the right thing. And very specifically, back to what I was already learning, that it is money and margin, even in nonprofit organizations, that often drives our behavior and our decision making. I had done some teaching prior to this time, but I had done much more work in community. So I decided to take my same participatory approach and work with those people whom I intend to serve, and those were our students. So in the spring of 2020, I ran an elective called Creating a Curriculum in Medical Business Ethics. These are the students who worked with me. I want to say a couple things about the picture. One, if you look carefully, you can tell it's Good Friday. I'm sorry, Ash Wednesday, because you can see some people had been to church. I also want to call out on the left, you see Rachel Pion and Joseph Rojo. They graduated from SLU last year, and they are both residents within the UCSF system. So I hope you're treating them well. We miss them very much. This group of students really came to me and said, if we're doing this curriculum, we need to ground it in the values of the medical school that we learn about when we do our white coat ceremony at the beginning of medical school. And that white coat ceremony speaks to our mission and values and talks about preparing people to be leaders It means that we are committed to providing care to all patients, that we're committed to social justice, and we have an appreciation for all the factors that affect a person's state of health or illness, including their insurance status, whether they're on private insurance, Medicare, Medicaid, or no insurance at all. We also decided we wanted to be creating a practical ethics toolkit to complement the medical toolkit that we prepare students for, and that we were going to be doing some work through lecture and then a lot of the work for this course through small group, in addition to independent work and reflection writing. In terms of kind of what we call the structural content, that's pretty straightforward, although we don't always teach it right at the beginning of medical school, and for some students, it's a little overwhelming to learn some of this stuff this early because they hadn't thought about it before. So in the fall of the first year, we have a full session on insurance and patient care. Students have to go look at their own insurance coverage and kind of learn what the copay, co-insurance, deductible, all this stuff is for their own coverage. We then kind of divvy up states around the country, and students look up Medicaid eligibility by condition and income level. And then they learn about our region's so-called safety net organizations that are in place to provide care for our low income and underserved populations. In the spring, we have sessions on how physicians get paid, and we are still in a part of the country which is really driven by fee for service and by traditional RVU. And so during that time, we also think about how comp plans for physicians can incentivize certain kinds of behavior. There's content that I teach them on the leadership side. So they learn about the emotional intelligence constructs, self-awareness, self-regulation, the importance of empathy. I expose them some to the work of Jonathan Haidt and his work about the values and how those are both overlap and diverge for people globally who would identify as progressive versus conservative. I also introduce them to behavioral economics, and in this course and in our clinical diagnosis courses, we're also talking about cognitive biases. And in particular, I have students do a training session on prediction, decision, and action bias. Then there's a lot of skills development in the course. So here's where the work on kind of self-reflection, self-awareness, moral humility, structural humility, perspective taking, teamwork, and thinking in that lifelong learner mindset. This is where we do that. And so to be very concrete, I start them off at the very beginning of the course with something I called a values interview. So they've already been divided up into small groups that continue to meet throughout medical school. Because of the size of our class, each of these small groups has about 10 students in it. So from an LCMA point of view, it's a big small group, but anyway, about 10 students. And they're assigned a colleague where they ask that colleague, can you name a value that's important to you? Why do you call it that? What's a story you're willing to share that illustrates why this value matters to you? And then in their very first small group session, they present their colleague and their colleague's values interview. This is a beginning of a series of structured conversations for these breakout groups where they have done reflections, or we have some games or cases, or where they prepare questions for and then process what we learned from our physician panels. And what I'm trying to do in this space is have structured opportunity for disagreement, not from a debate point of view, but really from the point of view of having students kind of listen to their emotions during disagreement, see what those emotions might be connecting to in terms of values or their own experiences, intentionally listening to other points of view, especially when they disagree with the speaker. And instead of, again, just debating the point, seeking to understand better where that person is coming from, how their own experience drives that core value or attitude that they would have. The other thing that we do in this small group is because the content around insurance or physician comp is so enormously huge and ever-changing, they also pick self-directed learning topics. They then do research and report back to their peers. When we get into the spring of the first year, when we're beginning to talk about behavioral economics and cognitive bias, I also have them think intentionally and write a reflection on what puts each of us at risk of acting against our values. We have a session where I talk about a malpractice case, and I've had other colleagues present with me. And there, what we're trying to do is normalize that we are all human and we all make mistakes. Just a little bit more about the curriculum and then kind of stepping back again. So in the final assignment in the pre-clerkship, they get to come up with a thought exercise, an innovation assignment, what's something you want to change or improve. I originally assigned, you can pick any topic in medical care, public health, or medical education. Students, many of them pick physician well-being topics. And so the assignment is, what do you want to create or improve? How does it connect to your values? What biases, blind spots, ignorance, and lack of experience could get in the way, and what kind of people need to be on your team. Although these are just thought exercises for a number of students, these are projects they're already working on, and so there's been some exciting work that then I've been able to join them on or connect them to the right people so they can take their ideas forward. All of this, and here's where we start to get into the uncertain space of uncertainty, is really my attempts and our collective attempts to help students become more uncomfortable with being uncomfortable, to realize that for some of the most complex problems within society, there's no easy fix. Back to, if you jump to a solution, that's potentially going to create more harm than good. And also, it's another way of emphasizing the importance of teamwork, that some issues are so complex that we can't really process them if we aren't working with each other. The other thing that I've realized that we're doing is to help students think ahead to their careers, where it's not just, am I going to be internal medicine or psychiatry? It's going to be, where in the system might I want to work? Do I have policy or advocacy issues that I'm interested in? And we have another course called Medicine and Society that really builds out this advocacy piece of our education. And then after that, first pre-clerkship period with those 3 semesters with me, there are other scaled up opportunities for students. So I can come back to this, but I do formal training for second year students so that they can facilitate the first small groups of the first years. Talk about when and how that developed if you're curious. And then, as I mentioned before, those same groups continue to meet during the clerkship year, pull them back together. They meet on their own. I give them discussion prompts, and they often use those times of meeting together. These are 5 or 6 days throughout our clerkship year where we pull students out for a day. And so it's time both for reflection and a time for peer support. So this is what I said I would describe some of my our attempts here to create educational opportunities for students that prompt for self-awareness, moral and structural humility, perspective taking by listening to other points of view and understanding that everybody's coming often from a place of very deeply held values, the importance of teamwork, and then overall with medicine, really helping foster the notion that it's not memorize and master. It's really committed to lifelong learning across our medical specialties, but also in the social and policy context as well. What I want to come back to then is this role of uncertainty. And this is where I really, as I said to Margot, I have questions, not answers. But I have realized that one of the things that is so tricky in this space is if I'm trying to help introduce how big some of our social problems are, how unclear certain solutions are, if I'm trying to make students more comfortable with that zone of I don't know yet, which I think is super important in a variety of ways for future physicians, I'm also doing that during a time of life where they combat a lot of uncertainty about what the future holds. And here, and this is an image I found because I wanted to find something that illustrated the notion of headwinds. So I found this poor little puppy dog. Here I want to come back to this question that I know our students deal with is, how do I distinguish myself? What is it I can do beyond my coursework to help represent to the residency program I would like to match in that I'm worth their while? And so here, I'm going to wrap it finally back to us and then hope to open this up for more discussion. I do want us to think about what can we be doing as educators, as faculty members, as colleagues, as mentors and advisors. What can we be doing to help address this space of uncertainty? I say this because when I talk with some of our students, and especially after we closed our student-run free clinic here, some of the pushback was really about this space. I had students come to me and say, well, if I don't start my own clinic in med school, will I get into residency? And this reminds me of some of the pressure I hear from high school students applying to college. This notion that if I don't, and this is a horrible pressure that people experience, this notion that if I don't start my own company, I'm not going to get into a prestigious college, or I'm not going to get into a prestigious med school, or I'm not going to match for residency. And so here, how do we begin to shift a culture so that there's less pressure for people to be feeling as though they have to achieve change that, in my experience, has often taken me 3 to 10 years? How can we continue to really support students and to have processes through the whole residency application and selection process where what we're looking for is sustained commitment to something, not necessarily successes, but ongoing learning? How can we continue to send the message that what we care about is that people are curious and committed to learning over the course of a lifetime? And how can we find this place where students can distinguish themselves by their willingness to serve, even if that isn't very glamorous work that they're being asked to do? Along with this, and this goes both to my role within the coursework, but also within the community-facing work, as we want our students to engage in meaningful service opportunities, how do we make sure that they're partnering appropriately with community organizations so that it's not just a benefit to the student, but to the community organizations and members of the community that they serve? And how do we continue to have complementary professional development programs that really prepare students for this space? I'll note that not every student wants to do public health or system change work, and that there are other really important pathways around research or other types of skill sets within the physician profession. But again, here at SLU, because there's such a legacy of service and because so many of our students have this intention to make the world a better place, it's for these students that I want to really think carefully together with all of you. So that's what I have for today. I did my introductions. I talked about my course. I came back to this notion of student pressure, and now want to really open it up for your comments, questions, and discussion about what we as a community of educators can be thinking about and doing. So thank you. And at this point, I'm going to stop sharing. Oops, I'm not hearing you.
You did. Sorry, I'm muted. Katherine, I want to thank you for a truly thought-provoking discussion. I agree on the more questions than answers, but it seems to me that that is just sort of where we need to be right now as educators, with a learning mode and some humility. One question that I think one question that comes up, there are many questions that come up from this work, but I guess I was curious to learn a little bit more. I mean, you talked about sort of for students, the tension between, balancing performance, like I did it within a year, it all got tied up in time for my residency application. Or I know we have some folks on the call who are working in the pre-medical space, or in time for medical student application and for medical school applications, the tension between making, as you mentioned, a longer, more sustainable, more impactful impact in the community by gradually earning trust. And each student recognizing that maybe they're going to just be a small bead on the chain as opposed to, the entire necklace and chain itself or something like that. When you talk about that with students, I guess I'm curious to know what your experience has been. Like, how do they respond? How does this play out in terms of students' sense of mental health and stress? I'm interested in hearing more. Thanks.
Yeah, so I think what is really hard is that I don't want to give our students false promises. So with step one going pass fail, and because of all the changes that happened during the pandemic with remote interviews, and I know kind of the number of programs people apply to has gone way up. I don't feel like I can say, don't worry about all these other activities that you're doing. And I have this conversation with students around research and the community work. What I typically try to do is help students early on begin work that they can continue during the 4 years, even if they have to take a break for a year during the clerkship. And then this is just my idea. I have recently asked our junior students to say, so with your residency application now, you have to talk about 3 meaningful experiences. Think ahead to the kind of story you would want to tell and use that to help you decide what you will and won't do. Because part of the tension here, it's related, but it's not quite the same thing, is students can get spread very thin by taking on a number of different activities. And so it's my hope, and that's where I think it comes back to us, that if we're emphasizing sustained commitments, learning from things that didn't go well, that maybe students will realize that it is the quality and not as much of the quantity or just the I once did a talk here a few years ago called "We Only Tell Success Stories," right? So there's all this pressure. And I know some schools have done curricula around learning to fail. So it's all in that same space, but uh, I have compassion for the students because there is real uncertainty in this pathway.
Thank you for sharing that, Catherine. That's great. And there's many comments in the Q&A, so I want to just share some of them and let you respond to them. Kayla wrote, "Love this talk. Thank you so much," which I would agree is so important. "Is there a course that we can take that covers a lot of these topics or themes?"
So not yet. I will say I just met with Steve Bander of the Bander Center again on Wednesday, and he does hope that we can build out some of our web offerings. What's on our website now, and I didn't think to come prepared to post links, but there's something we use in our 4th-year capstone. So after the match, prior to graduation, we do have it's called Controversial Cases. And so these are stories, this is thinking ahead to end of med school, but stories, and then from end of med school, thinking ahead to the first job, stories about compensation structure or incentives, contracts or malpractice. And so some learning opportunities there. So those are interesting. They're available for public use. It's a piece of this space, but there's this whole other leadership component. I mean, for me, a lot of that, and I'm not advising everyone do as much school as I did, but a lot of that was really covered more in the MBA, especially doing work in teams.
That's great. That's very helpful. Thanks. And then Jay wrote, "Clinicians often fall into leadership and management roles in academic health centers. What is the role of senior and professional staff in professional development and career trajectory who are part of your organization?" And I'm going to piggyback another question onto that, which is also, what is the role of all of us in any position in advocating for change in this sort of landscape?
So I'm going to go to Jay and say there are a bunch of us here in our dean's offices who are physicians. Many of us still do patient care. We have other team members. We have our learning specialists, so PhD trained and master's trained. We have a psychologist who both does just does a whole lot, but does a lot in our wellness space. And then for each of our med school years, we have a staff program coordinator. And those are really the folks who, it's often like frontline staff in the clinic. Our med student coordinators, they often know the most about what's going on with students as a class. And I will say I have worked in a variety of settings and organizations, and I am very happy that we really work here from a team perspective. We also have some other PhD, education PhDs on our team. So I do believe here that we see this as collective responsibility. And I guess just want to use that to then emphasize what I was saying before. When issues are complex, it's hard for anybody to do these one-off. And so I think we all need help from each other as we're doing this work. And then I know there was a piggyback part, but I don't know if I quite got the response to that.
I think you did. It was really not just related to staff, but just all of us, including, faculty, educators, and everybody.
I guess the really hard thing, and my joke, and students laugh at me because this was from the early days of Zoom and webinars. One day I was like, I've got gray hair. So I guess part of what is hard is I was conditioned, I grew up learning only to tell the success stories. That if I told about times that I struggled, that was going to be embarrassing. And what I have had to, I've really had to unlearn that. So the first year I did that session on where we're all human, we all make mistakes, and I talked about my malpractice case. It was a case that settled over 20 years ago. But to get up the courage to talk about it, even when I knew it was important to do, I feel fortunate that I told a student I was going to do it because I had committed out loud. And it was very hard to do because it's so countercultural. So I think the degree that we let each other be human and less than perfect in a profession and environment that has traditionally hasn't allowed for that kind of space. I think the misinterpretation is that to be vulnerable is to be weak. But I'm gonna go Brene Brown here and talk about vulnerability really being a source of strength. And to those who really do love this topic, I would recommend Brene Brown's book, Dare to Lead. So that's work that can be done individually with a lot of exercises that get in the same space. I do not get money from Brene Brown. It just occurs to me it's a good resource.
Thank you for the suggestion and the disclaimer. You have a lot of questions in the chat here, so I'm going to make sure you get time for all of them. Jose asked, what characteristics or motivations for leadership in medicine have you found are most difficult for students to develop, and which have come most naturally? And I would add that, I think part of the question for me, and I imagine for Jose too, is not just for medical students, but maybe even for pre-medical students or pre-health students, thinking of all residents, all pieces of the spectrum.
So I think one of the things, and I do think most of what I teach isn't on step 1 or step 2, but there are some questions when I did the practice banks a few years ago on leadership theories. And so I think it is interesting to think about what do we mean by leadership, because there's the leadership I have by a title. And then there are other models of leadership which may not actually even come with a title. People may not even be formal leaders. And where the space we're in is in that servant leadership model. And also the language that gets used, I think it's transformative leadership, where the role of the leader is really to be supporting an entire team. And so anyone, and we had a dean here a few years ago who was very top-down leadership and didn't do a lot of collaborative work and didn't last very long. I think anyone who just thinks leadership is about having the title and being in charge is likely to stumble. It's not that people can't stumble and then learn, but that's where I really see folks get into trouble. I'm really trying to get students to think about, what do you care about deeply? Why do you care about it? What are the things that bring you passion and a sense of energy? And then that's a zone and that you can work in. And that's why I say leaders and change agents, because you can change things without actually having a formal title or role.
Thank you for that perspective. It's so important. We have actually a two-part question and comment from Aisha, who wrote, thank you so much for this talk. Is there a talk or session given on some best practices in community engagement for students, faculty, and staff that want to engage in community partnership work prior to engagement with the community? Boy, I would love to hear the answer to that one. And let me just add the rest, because Aisha has done a lot of work in this area, and she added, one approach we've done in community engagement work is to identify organizations that are engaging in policy work and support our students to work on currently existing community-based efforts, which I appreciate your adding, Aisha. Thanks.
Yes, so and Aisha could give that talk. As a big resource, I think of the organization Community Campus Partnerships for Health. My own method, having been in East Africa and dealing with my own drive for success and seeing the harm caused, my rule was for me to come in, and I need to come in from that servant role. And so most of the areas where I have really been able to be part of big change initiatives, these are ideas that have come from communities. We're not talking about this today, but I'm currently building programs for people coming out of incarceration. And so we have a prison education program. And one thing I did last fall was go meet with inmates in one of our prisons to ask them, what do I need to know for this work? And so that's why I come back to the fancy term participatory. I think it's really coming in, learning, building relationships, being of service, being willing to do things I might not even be that interested in. And then just by being in this space for me moving forward. And then to Aisha's point, we're working with our community partners in this programming for people coming out of prison and jail. How do we create an ongoing program where there are truly formal official roles for students? What kind of training will we do beforehand, and then to carry that forward?
Thank you. That's a wonderful answer. Thank you. I want to add Kayla's suggestion from the Q&A, which she said leadership and organizing for change course through Institute for Healthcare Improvement was fantastic in teaching this type of leadership.
Cool.
So
Thank you. That's a great resource. We've had a little trouble with the IHI website recently, but I will try to go in and find that.
that's great. Thank you. And then maybe one of the last comments we have time for is from Josh, who wrote, "Thank you for this presentation. I'm curious what you've observed, maybe during the Ferguson uprisings or other time periods, regarding the tension between the urgency of advocating for our communities while balancing the demands of medical training, and also the tension between the risks that students and faculty sometimes take on in our advocacy and how we balance protecting our trainees while also backing them up."
Oh my gosh, so many important thoughts. So this comes back really to working with a number of stakeholders within the community. So I mentioned that we now have much more coordination across our safety net. That's through two entities. One's called the Regional Health Commission, and the other is the St. Louis Integrated Health Network. And so all of these organizations, and then we have had the Ferguson Commission, which continues, has a great publication called Advancing Positive Change. So I think there's been a lot of learning across the community about how best to respond to a number of the issues that came up from Ferguson, but those are all these very long timelines. I think with our students, again, I guess I have this notion of scaffolding. So they're on the front end, it's helping students understand that there's a very embedded historic context here. Helping students know that just to learn about a problem doesn't mean they're responsible to fix it. And then really working to find, and a lot of the work I encourage students to do in community is not medical so much as really just service, just being available, being willing to do what an organization asks of them. And again, in that relationship building space.
Yeah, that's an important answer. And I think for me, a lot of this comes back to exactly what you said at the beginning. More questions than answers. I want to just thank you for your beginning this dialogue for all of us, and hopefully giving all of us something to think about and to work together on. I appreciate you opening the conversation because I think it's such an important one, and I want to give you the final word that you'd like to share with us before we close out Grand Rounds.
So in the spirit of building relationships, I know you have just a little less than an hour with me and that there have been a bunch of questions, but I do welcome remaining in touch about this. I do think it's really important for us to talk about these issues as a national community of educators. So that would be my request back.
Well, thank you. That is, I think, exactly why we're doing this. And I really hope that everyone will be in touch. And Katherine, thank you so much for your work in this area and for sharing your thoughts with us today. And thanks everyone for joining us. Have a great afternoon.
Thank
Bye.
you, everyone. Bye.